welcome to your makeup of 2020 fourth quarter BLS-ALS interaction, which was trauma this year. And in the fourth quarter, we started off strong in November with live classes with trauma evolution, and the feedback was pretty good on that. Unfortunately, in December, real live classes were shut down, and we're looking for a quick way to capture the information and give it to you succinctly. And so this is what we came up with. Not perfect, but I think it will do in a pinch. So let's get started. For those of you that I haven't met within the consortium here in Northeast King County, my name is Dana Yost. I'm the training paramedic, and I'll guide you through this. Here we go. So first of all, our goals today around trauma in general is to, one, stop major bleeding. We're going to talk a lot about the rapid trauma exam, rapid packaging, and rapid transport so that we can really meet our ultimate goal, which was getting to a surgeon within the golden hour. So we rely on each other heavily as a team to be able to accomplish all of the necessary things that need to happen in a trauma, which in its sense is pretty simple. But at the same time, it's not easy. So we'll kind of walk through those and give you some tips and tricks as we go along. So first thing we should talk a little bit about is the trauma management guide, which just basically lays out the roles. And we talk about when you respond and when you arrive, the things that you need to think about doing, which is the same things that you normally do on a fire, for instance. And doing a scene size up and making sure that the scene is safe, and setting up command, and calling out how many patients there are and what colors they are as far as their seriousness of the nature of their injury. Those are all things that I feel like you do a pretty good job at. And so we're going to kind of gloss over those and really talk more about the trauma patient itself and the main roles that are associated with trauma that we'd like to become the standard on all calls. We see this on many calls, and those calls run great, and every once in a while we have calls where we as a team miss the mark a little bit. And I think some of that is making sure that we're all on the same page. So let's start off with a rapid assessment, and that's done by a patient advocate. And so one of the EMTs should be thought of as the patient advocate, and we'll talk about that a little bit more. But that's a person who's going to be with the patient from the beginning all the way to the hospital, whether that's in the BLS unit or that's in the back of the medic unit. We rely heavily on information that you acquire before the medics get there, and having a patient advocate at the hospital who knows the answers to all of those questions is super helpful for the hospital when it comes to trauma patients, especially ones that aren't responsive or can't answer questions on their own. We talk about rapid packaging. That means we're going to do a quick rapid assessment first, which would be a kind of a head-to-toe that's abbreviated. We'll talk about that a little bit more. And then we're going to quickly get them immobilized so that we can get them into the back of a transport unit and move quickly. Our intent is to be on the scene for no more than 10 minutes. And so that's kind of our goal, ideally less than 10 minutes. And that relies heavily on the first and second arriving units to really be on top of their game to make sure that all of the information that we need is acquired and the patient is immobilized and packaged and kept warm, and that there's a patient advocate to go along with that patient. So when we think about the roles, I kind of think of four main roles. There's the patient advocate that we've talked about, and then there's a driver, which would be an EMT as well, that generally knows the way to the hospital. And then there's a medic officer that's generally the medic in the passenger's front right passenger seat of the medic unit is the person who's in charge, who will go and make contact with the patient advocate at the scene. At the same time, the medic who's in charge of skills, which is generally the driver of the medic unit, will just simply get out and go into the back of the rig and start setting up with the intention that they're setting up for a significant trauma patient. And then all of those things lend an ear to rapid transport and making sure that most of the things that need to be done that are basics are done, so that when the patient gets into the back of the truck, a secondary exam and some further treatment can happen on the way to the hospital versus sitting on the scene and waiting before we move. So with that, just remember that there's an audible, right? At any time, command or the medics may change the flow of that evolution. There may be some variance in that particular call that changes the behavior of us as a team, which may be as simple as extrication or prolonged extrication, or it may be as complicated as a complicated airway that requires more hands than just the two medics in the back. So we all want to have a common understanding of the basic roles that are associated with success when it comes to trauma patients. And a patient advocate is the number one thing, along with a medic who's in charge that interfaces with a patient advocate to get very quick and timely and concise information about what's been going on and what's been done and what maybe still needs to be done. And then an EMT driver and a medic who is the medic for skills that literally gets out of the driver's seat and climbs in the back of the truck and starts setting up. Okay, so let's talk a little bit about roles and just see what those look like. Here's a patient advocate, and you know, some of the audio is not perfect, but I hope that you'll at least get the sense of what we're looking for.
I'll be patient advocate. I need a backboard and a seat collar.
So notice that the patient advocate says she's the patient advocate. It goes right to the head of the patient. That's really a great place for a patient advocate because somebody's got to hold that head while we get things immobilized, and that really locks a person in so that they can't do other things. So it's a great place for somebody who's in charge to put their hands on the head and direct others to do some of the work. And that allows you also to kind of stand back a little bit, not get tunnel visioned into doing any one particular skill, and be able to direct and manage the rest of the team. So remember that the patient advocate is ideally someone who first contacts the patient, understands what happened, and understands what has been done as time has progressed, and can really stay with that patient all the way to the hospital, so that even with the medics there, we weren't there in the beginning, and so there's many things that we don't know about that you may have forgot to give us, and when somebody asks us for that information and we don't have it, that's not great for the patient. And when you're there and you can say, oh, well, that's because of this, or this is what happened, that can be super, super helpful in patient care at the hospital. Okay, so next, let's just take a quick look at the rapid trauma exam. Notice there's a theme here of rapid trauma exam, rapid packaging, and rapid transport. That's really our three goals. So notice she starts at the head, she goes to the chest, she misses the belly, goes to the pelvis and the femurs and checks for a radial pulse. So this is very deliberate. As we look at the head, we're looking for you know, the basic things that you would normally look for in the exam, but we're also assessing, you know, is the airway open and does the airway need suctioning? Do we need ventilation? Those type of things. So this is a quick down and dirty of things that you should check that you can really do something about, or that we can do something about to potentially save a patient's life. And the airway for sure is one of those things. The chest, and understanding how badly the chest is injured can help us to expedite treatment that might save a life in, for instance, a tension pneumothorax. And so her visualizing, seeing that there's bruising on the chest, and is there crepitus, is the chest stable, etc. can be super helpful. Now, notice she misses the abdominal exam, and I think really if you think about this, in the primary exam, looking at the abdomen as you pass through to the pelvis is probably very reasonable. Do I see any bruising there? Do I see anything that's really obvious? Is there a knife stuck in the belly? But palping the belly really is not going to change what she's going to do there on the scene before rapid packaging. And I think we also need to stress that there is always going to be a secondary exam and continued exams on the way to the hospital in the back of the medic unit. And so if you say, you know, there was bruising on the belly, but I never palped the belly, we totally understand that, because it really isn't going to make a whole lot of difference in what you do right then or right when we get into the back of the truck. Whereas putting a flutter valve in somebody's chest or making sure that we suction the airway because it's all full of blood and they're not breathing and they're gurgling on their, not breathing well enough on their own, those can be super helpful. So she passes over the belly. She looks at it as she passes. She looks at it and she checks out the pelvis to see if it feels like it's unstable. And then she quickly just touches on the femurs on both sides, and notice how she kind of does that kind of push-pull type movement to see if there's anything obvious and broken there. And then she goes right to a radial pulse, and all those things kind of tells a whole lot of information. We know a lot about the airway. We know a lot about the face and the skull. We know a fair amount about the chest. We know a little bit about the belly. We know a reasonable amount about the pelvis and the femurs. And we know that if there's a radial pulse, there's a blood pressure of probably 90. If there is no radial pulse, then you should probably look a little further and see if there's a carotid pulse, for instance, to tell you that the patient, one, is alive, and two, what the quality of the blood pressure is. So those things can be super helpful. And you notice that didn't take her but 10, 15 seconds at the most to do a rapid trauma exam. Next, we'll look at the medic skills. So we looked at patient advocate and the patient exam, which could be done by the patient advocate or could be done by someone directed by the patient advocate. And next, we're going to look at the medic skills. So this is the guy who's driving the medic unit, guy or gal, and they get out of the driver's seat and they hop into the back of the truck and they start setting things up. And historically, in very sick patients, those patients come to the back of the medic unit really, really quick. And so, sometimes we can hardly get anything set up back there, but there's a lot of stuff that needs to be set up. And so having the driver that's going to drive to the hospital assigned early and sent to the medic unit to help that skills medic setup in the back can be super, super helpful. You can imagine a patient who has not a very good airway, who's unconscious and unresponsive, who maybe has a pneumothorax. There's a lot of work that needs to be done on that patient. And if we arrive and they briskly are put into the back of the truck, we can get behind really, really easy. So this skills medic's going to go back there. He's going to put the monitor in place, get the leads out, get the blood pressure cuff out, get the SAT out, probably set up a tube, work on getting some IVs set up, hopefully with the help of the EMT driver if they get them early enough. So that leads us to the EMT driver.
I'm the driver. How can I help you set up?
Pull the gurney out, then you can come in and help me set up some fluids.
So a couple of things here that can be helpful is, one, move the gurney out, lower the side rails, pull off the blankets and the towel and get them out of the way, maybe up front, in the front of the back of the medic unit. The idea here is if we take the stretcher to the patient, it's twice the distance it is taking the patient to the stretcher. You got to bring the stretcher out there, put the patient on it, and then bring the stretcher back. Whereas if you just take the patient who's been secured with a C-collar and some straps, remember our 4-strap rule, and a headbed, there should be good to go with a couple of people on each side of the backboard. Should be able to make it to the stretcher more expediently than taking the stretcher to the patient, unless there's some extenuating circumstance where it's taking longer and you're looking for things to do, then you can bring the stretcher over there. Not a big deal either way. The other thing is on the back right-hand side of our medic units is where our yellow backboard straps bag is, and that's on an outside compartment. And so ideally, either the medic who's the skills medic or the EMT driver who's going to come and help should grab that yellow bag and throw it into the back of the truck. And that way, on the way to the hospital, if we find that we're missing a strap here or there, we need to redo the head bed or something like that, that stuff is in the back of the truck and available to us. So those are just style points: getting the stretcher out, getting it ready, and getting the spinal mobilization yellow bag out of the right back compartment and putting it into the back of the truck someplace. Those are nice style points. So our expectation is the EMT driver comes, asks what he can do to help, and the paramedic, who's the skills medic, who's in the back setting up, will direct you on what you can do to best help him. Okay, next, let's take a look at the medic who's in charge with their first contact with the EMT patient advocate.
I'm the medic in charge. What do you have here?
I'm the patient advocate. Here's what I have going on.
So there's a patient advocate that's listened to what's going on, has asked other people to do things that she needed to get done, understands the condition of the patient pretty well, and a medic just coming up and saying, "Hey, I'm the medic, what's going on?" to everybody probably is not as expedient as going straight to the patient advocate and saying, "Hey, I'm the medic in charge. What's going on here? What can I do to help?" And you'll see that the medics will try to push you a little bit to expediently package that patient so we're ready for rapid transport. So rapid packaging, rapid transport, that's what we're after. And a quick, easy story, and really all we're looking for is, here's what I've got going on. You know, this patient fell 18 feet out of that window onto some rock and some beauty bark, and was unconscious when we got here, gurgling with a bloody airway. We turned the patient over, did some suctioning. The patient's breathing on their own. These are the things that I've found. Here's the things that we've done for them, and here's the things I'm concerned about, right? So you use that, the cuss phrase, which says, here's what I'm concerned about. That's the very first part of good communication, is letting people know what you're concerned about. So that's the medic in charge making contact with the patient advocate and expediently working towards moving the patient well packaged towards the back of the truck. And it's not super helpful to put a patient in the back of the truck with one strap on and no headbed. And yes, we can get them there faster to the back of the truck, but then that's a lot of things that need to happen in the back of a truck, which is not very big. So do it on the scene and do it expediently. A good packaging, even if it takes an extra 15 or 20 seconds, is probably well worth our time versus trying to do it in the back of the medic unit. Okay, so then when the patient arrives at the back of the medic unit and is loaded into the back of the medic unit, this is where the EMT driver moves to the driver's seat, right? And so if you're doing something that requires you to do that, then finish what you're doing and move into the driver's seat. If you're doing nothing but standing there, then you should automatically think, if I'm the driver, I should be in the driver's seat. We don't want to spend another 3 minutes getting people out of the back of the truck and moving them into the front so they can get ready and acclimatized to the things in the front of the truck that you're maybe not used to, because our trucks are a little bit different than everybody else's. So knowing where the radio is and where the mic is and where the MDT is and where the horn is underneath your left foot, those are things that you learn over time and with experience. And so the sooner you get up there, the more time you're going to have as the EMT driver to really get familiar with the front of the truck a little bit. We also would hope that whoever is assigned as the EMT driver is somebody who knows how to get to Harbor View, which is most likely where we would take a trauma patient. And generally, going across I-90 is going to be a better route just because there's multiple lanes of traffic And right now 520 is a mess with construction. And if it's heavy, having to split the center is much more difficult. So plus getting over on I-5 in that area is pretty congested. So I-90 is a better choice generally, but understanding how to get to Harborview and how to enter the ramp at Harborview is super helpful. So somebody who has some knowledge about that would be helpful.
Who's my driver? I'm your driver. Once you get around the front, we'll tell you when we're ready to drive. Okay.
So that's relatively simple. I think those are the four main roles that we would hope that we could all have a common understanding of, so that we work together better and more efficiently. Okay, so switching gears just a little bit, talk a little bit about tourniquets. And we talked about the rapid trauma exam, which really isn't part of tourniquets. That's more part of the blood sweep. So we should be thinking when we walk up, should be kind of eyes on everything, trying to understand what is going on here and what's life-threatening. And is there a lot of blood, and where is it coming from? And you don't need to pinpoint it really close, right? A blood sweep, and it's coming from that left leg. All your tourniquets are always going to be high and tight, right? In a primary evaluation, like out on the street, you don't need to open up the clothes, figure out where the bleed's coming from, and put the tourniquet 1 to 2 inches above the bleed, right? It's high and tight up on the extremities, and you catch everything that's down below that. When we come in and do the secondary in the back of the medic unit, then we can look to see if we need to adjust at all. But I think it's really easy just to keep it super simple and say, when you put a tourniquet on, it's always high and tight on whatever limb it is that you got a bunch of blood on that you're concerned about, and we'll make that adjustment later. Okay. And they can go right over the top of clothes, right? You don't need to cut off the clothes to get the tourniquet on there. You say, that's a big bleeder that's on that right leg. I'm going to put that tourniquet up high, and we're going to do it right away. So the patient advocate can get there, patient advocate and the team can get there, and the patient advocate can say, okay, I'm the patient advocate. I need a backboard and a C-collar. I want you to put a tourniquet on that right leg right away, ASAP. Let's go fast, right? So that stuff can get done efficiently, because yeah, it's great to have an airway and be breathing and have circulation, but if you bled to death, in the meantime, that's probably not super helpful. So high and tight on the extremities, that's part of the blood sweep, and as you walk up, you're doing kind of your start of your ABCs, and as the patient advocate, you're taking charge of the head, and then getting somebody to do a rapid trauma exam all at the same time while somebody else has got a board and a C-collar coming. That can be a very efficient way to take care of a patient on the scene, so you can get to the rapid packaging part of the game. The other thing to remember on trauma patients, you're going to need a backboard. Take an extra second and have one of your team members grab a backboard and the spinal immobilization kit, so that you're not having to go back to get that stuff. So that will save us quite a bit of time as well. Okay, so on tourniquets, I'm just kind of going to expand this a little bit so that you can see what I'm seeing. And so your tourniquets, they come something like this, and they come in a package, a cellophane package. If you still have them in your cellophane package today, I want you to take them out of your cellophane package. That's a pretty heavy cellophane, and with blood and gloves on, it will be a terror to you trying to get the wrapping off of these things. So take them out of their package. It's the number one thing. Number two is the way that these come. They come in some semblance of, when you open them up, they are in a big circle. And the reason why is because these are military tourniquets, essentially. And the intent is to be able to do a self-arrest, right? To be able to put this on my own arm with one hand and be able to tighten this thing up. And that's not really the way that we most likely will use them in EMS. And so the next thing that I want you to do is once you take it out of the package, I want you to open it up, right, and get it ready for your for whatever kit you put these in, right? And so what you'd like is you'd like something that you take like this, and you can come right over here around the patient's leg, and you're already on the way here. You didn't have to go slip it down their long leg and all the way up high tight. You can just get it right underneath, and you can come in here with the tail end of it, and you can go to work, right? And so the best way to do this is to undo that loop that we saw earlier, and then right on the back side here, you can just fold this just like this, and then take your Velcro and just do a quick little twist on it so that when it comes over onto the other side, it sticks. And so now, when we pull this out of the kit and pull the Velcro off, we're ready to go, and we're already in business. So think about how you might get those tourniquets ready, because we know when we actually need them, which is quite rare around here, it is not going to be a fun situation. So the better prepared we are ahead of time, the better. Right, I'm going to see if we can bring me back down to 0 again and drag me up here. So that's my tip on tourniquets. The other thing I would say on tourniquets that we learned in some of the most recent classes is that when you put these things on, put them on as almost as tight as you can get them before you start using the windlass. If you put them on loose and you have to windlass this thing 4 or 5 times, you did not put it on tight enough. So put it on nice and tight first, and really 1 to 2 at the most swivels with that windlass should be adequately tight. And we know that adequately tight is when it stops bleeding. So that's the tips on tourniquets. When it comes to hemorrhage control, remember at joints, right? Tourniquets are out. We don't use tourniquets generally on joints, although there's some little tips and tricks there that if you use tourniquets a lot, maybe might be helpful. But for us, when it comes to groins and armpits, coincidentally, armpits are the most common place that police get shot as they come around the corner with their gun aimed and their armpit up, their elbow up and their armpit exposed is the most common place, and that's obviously going to be a difficult place to tourniquet. So that's where use of pressure and use of packing might come in handy. But I would caution you about spending way too much time packing a wound in our type of situation. When you're out in combat and you're stuck in a spot and it's unsecure, and the best you can do is pack something so that it will stop bleeding, then that's understandable. But I think in our situation, the most likely scenario is that you're going to do some direct pressure. You're going to grab a trauma bandage and you're going to stuff it in there, and you're going to push on it really hard and point it with a couple of fingers. Remember that when you put your palm on something and do pressure, that's not really pressure. Pressure is find the bleed and put your fingers on it. That's pointed pressure, and that's really is what is effective. So, and then if we need to pack in the back of the medic unit, we can do that. But some pressure will go a long ways in those control of joint hemorrhages, which hopefully are relatively uncommon in our workplace. So with that, let's take a look at a scenario. So far we've gone over the 4 roles of patient advocate and the EMT driver, the medic in charge, and the skills medic, as well as taking a look at a quick primary trauma exam. And remember that a secondary exam is also necessary in the back of the medic unit. That should be one of the top priorities to make sure that we don't miss anything. Okay, so let's get ready for a scenario. This will require your attention, right? So pay attention to the details and use all your senses as to what you see and what you're thinking and what you think you might need to do. Look for clues, right? So there are some clues there. Ready? So some just basic, an overview of things that I observed. The first one is I noticed that they brought equipment with them, especially a backboard and a spinal mobilization kit, and the ability to do a little bit of airway management if they need to. And then as they walk up, I see a lot of blood, right? That is a lot of blood. To give you an example, when we simulated that, that was over 250 cc's of simulated blood that we used to make that picture. So that's a fair amount of blood loss. The next thing I noticed was the patient was unconscious, right? And then we saw a little bit of facial injury. So we can kind of look at, where they fell, right? We see some rocks. We see a little 2x4 type edging between the rocks and the beauty bark. The kid's kind of half on that. We see some trees around there, right? We saw a high window when we were walking up early. We do see some concrete, so it's always potential that he bounced off the concrete and into where he is too. So there's lots of information there to acquire. Okay, so let's just kind of go over that scenario that you just saw and take it piece by piece. And so as the patient advocate, you'd want to assign tasks, right? Probably be at the head so that you can maintain spinal mobilization of the head while you're also looking around and asking other people to do stuff for you, including a rapid trauma exam and rapid packaging. So that we can do rapid transport. As you walk up as the patient advocate, you should be thinking to yourself, is this patient alive? Hard to tell. And that's a lot of blood. So remember that that's when we did that scenario, that was over 250 cc's of blood that we used to create the look that you just saw there. So it's a fair amount of blood, especially for a child that's 5, 6, 7 years old, and that they're unresponsive. I think that you should be thinking to yourself, a tourniquet high and tight, roll that patient over quickly and maintain that airway. And looking in the airway once you roll the patient over and seeing, do they need suction, do they need ventilation? Those are basically, are they alive, stop the bleed, and airway are really your primary things that are of concern. And it used to be, we used to think ABCs, but we really think stop the bleed and then ABCs, because if you don't stop the bleed, all the rest of the stuff's going to go away anyways. Next is the rapid trauma exam. And so that's going to be a head, chest, pelvis, femurs, and check for a radial pulse if you haven't done that already. And that radial pulse versus a carotid member will tell you the blood pressure. We do not need a manual blood pressure out at the scene. You have many other things to do that are higher priority. We're going to rapidly package that patient. We're going to try and get them warm, get them covered up so that they're warm if you had to expose them. And we're going to get them onto a board if that's the treatment of choice, with a collar and a headbed, and get that head secured so that we can move them to the rapid transport mode. Just remember that you and I sit at about 97.5 on our temp, sometimes 98, right? But when you drop just 2 degrees, when you get into the 95 degree range, your ability to clot significantly changes. And so it doesn't take much. When they looked at this from the military standpoint, almost every single guy and gal over in Afghanistan that was critically injured dropped their core temperature when it was well over 100 degrees outside down to 95. So you can imagine around here in the Pacific Northwest how easy it would be to drop 2 degrees, and that makes life a whole lot harder for the patient. So we want to try and keep that patient warm and think about things like these novel heated blankets that BLS has started to carry in Redmond. They're about $20 or $30, and you open them up, they last 6 hours, and they're basically a bunch of heat packs that are associated with a blanket. It's disposable, and super easy. And you know, we don't have enough trauma here that we're going to go broke buying those things. So if we can do something to keep these patients warm. The other thing you can do is even if you just cover their head, right? If you take a towel and wrap it around the top of their head, so like this, so that you cover this area. That's what there's a lot of heat loss there. So that's helpful, as well as obviously putting a blanket over the patient. Be ready to interface with the medic. Really we want three things from you. What happened, what did you find, and what did you do about it, and do you have any concerns that I need to be acutely aware of right this minute? So, you know, this looks like, you can say this is a 7-year-old kid that appears to have fallen from about 18 feet from the second story window. This is where we found him. He was unconscious, unresponsive, bleeding profusely from a leg injury that we rapidly put a tourniquet on and stopped that bleed. We rolled him over, controlled his airway, put him on a board. Looks like he's got a big, huge bruise on his chest, and that's where we're at. You know, so we really don't need a whole lot more from you than just talk to us like a normal person would talk to another person in conversation. What happened, what did you find, and what did you do about it, and do you have any concerns that you need me to pay attention to right away. And then we're into rapid transport. That's efficiently move that patient to the back of the medic unit, and the patient advocate stays with the patient all the way to Harborview. That way there's continuity of care. Okay, so now we just kind of look at the same pieces that we just talked about, more in video. There's a lot of blood. Figure out where that blood's coming from, high and tight on the tourniquet, right? Then we're going to roll the patient over, and it looks like he's got some facial stuff. Let's make sure there's no broken teeth and blood in that airway that we need to take care of, and make sure that he's breathing adequately, right? At the same time, we can start getting things ready. Now we're into the rapid trauma exam. We're doing the head. We see a big, huge bruise around the eye and an open wound to the forehead that looks like a pretty good contact. Looks like a post nosebleed. We go to the chest, we'd palp that, we'd visualize it and palp it, right? And if you have the opportunity to get some lung sounds, that's a perfect opportunity as well. But a lot of bruising on the left side, and there's crepitus when I palpate the left side of his chest. You know, that's all the information anybody really needs at that point. And if you said, and there's decreased breath sounds on that side, or there's no breath sounds, that could be helpful too. Then we're into rapid packaging, right? We're into get them on the board and get a collar and spinal mobilization on them and move them to the stretcher so we can be moving in the right direction. So putting that all together, I think, you know, it'd be great if you had the opportunity to do like the crews did in November and actually do the work out in a simulated environment. Unfortunately, we're not there. But I think putting it together, we could say BLS needs to have a patient advocate, right, that stays with the patient and directs care so that it's coordinated care. That's super important, right? You need to have somebody who says, okay, here's what we need to do, and here's how here's what I need you to do, and what I need you to do. That's basically delegating some of that responsibility. And then when the medic unit arrives, the medic driver goes to the back and sets up. EMT driver goes to help him set up. And then the medic lead goes to interface with the patient advocate to figure out what happened, what you've found, and what you've done about it, and what concerns you might have. And then once the patient's loaded into the back of the medic unit, the patient advocate should stay in the back of the medic unit with the medics and the EMT driver, if at all possible. That's the time that the EMT driver should move to the driver's seat. If you're doing something critical, finish what you're doing and then say, I'm your driver, you want me to move to the front, right? That's easy. That's an easy transition. But you should also know that that's your cue when the patient gets moved into the back of the medic unit. If you're not directly involved in doing something critical, or someone asks you to stay even though they know you're the driver, it's your cue that you should probably go to the front seat and start getting yourself acclimated to the front. And then just remember, this is a team effort, and what we do hinges significantly on the foundation that you do as BLS providers, and so that's super helpful for us when we're all working from the same sheet of music. The last thing I'd say is, as the driver, what happens in the back? You know, a lot of people don't get to see all of that, and there is a lot of stuff going on, from medics doing skills to a patient with an airway that can easily be lost, to all kinds of cables and IVs and stuff all over the place, and medics and people having to stand up occasionally to do things, or medics that are talking on the phone while they're trying to do 3 other things at the same time. And so there's a lot of stuff going on in the back. Certainly a secondary exam is going to be one of our priorities, and then treatments based on those findings of the secondary exam. Certainly those patients will get multiple IVs. They probably get airway management in some way or another, and we may put needles in their chest, and we have to be able to monitor their vital signs, and we have to be able to converse with the trauma doctor on the phone. You know, CPR could even be going on in the back. So it's super important that you as the driver understand that you want to be speedy and you do want to be efficient, and we do need to get there in a reasonable amount of time, but also remember that there's a lot going on back there, and you're responsible for those people back there when you're driving down the road. So we ask you to be thoughtful about how you drive and try to be efficient. So in summary, you play an important role in whether a trauma call goes well. And just like CPR and cardiac arrest management, we want trauma to get to that same level where we're all working together in concert, and your foundation is what we build on. And if there's not a foundation there, then it makes everybody's job really hard. So let's work together on trauma calls, and hopefully that's helpful. Remember, the 4 main roles are patient advocate and EMT driver, medic in charge, who's usually the guy in the passenger seat on almost all calls. So if you come up to meet us at the side of the truck, the person usually you want to talk to is the guy who's in the passenger seat, not the driver. And then the medic that's in the driver's seat is doing skills. So there, you know, many places that we need your help and support in these positions, and we look forward to opportunity to work with you. Just remember that if you remember nothing else, I suppose, rapid trauma exam, rapid packaging, and rapid transport. Thanks, and have a great day.